Hello, this is my contemplative journal number 2 for Nurse 341. This is Jacqueline Bale. It is April the 15th. I will be talking about various topics such as patient safety, biopower, BCNU response or announcement about minimum patient ratios, amongst a few other things. So to start off, I want to talk about Interior Health's website, trying to reassure clients that they do their utmost to ensure quality, safe care for their patients and encourages patients to provide feedback on the care received. However, this seems like lip service to the public when applied to situations like the Redonda Vought versus State of Tennessee case. In situations where patient safety is jeopardized, often health authorities will respond by job termination or suspension. Often, safety issues surrounding patients are linked to poor administrative supports in place. So instead of putting the blame on frontline nurses for jeopardized patient safety issues, health authorities should report to the public on what measures are being taken at an administrative role to support health. That is my opinion. So I want to talk a little bit about the Redonda report and about the situation where she was trying to override access to a medication. So I feel as though on an administrative level, having an override option seems to be a setup for problems. The fact that a person can just easily log in and override the system. Um, and I feel that if overrides are going to continue to be in place, there should be a second witness um, witnessing the override to prevent medication errors and also to help combat alarm fatigue. So when the pop-ups or notifications come up saying this is a hazardous medication, having that second set of eyes to read that, okay, you are taking out this medication. And when they say, well, actually, I don't want to take out that medication, I want to take out a medication called Versed. On the topic of intersectionality, um, my mind kind of went on to a somewhat related topic of intersectionality. So while the postings on Moodle talked about things like your political point of views, your gender orientation, um, how all of those characteristics of a person can um, play a part in um, health equity. Um, I want to talk about how there is some intersectionality um, issues to provide safe patient care. So, such issues that intersect each other include new grad hires, understaffing, and horizontal violence at work. So, when all of these issues are in place, when it's a very high stress work environment, um, in the concept of new grad hires, the if the nurses don't feel confident in themselves um, while they're trying to take on a heavy caseload, um, then there's a more likelihood of um, poor patient outcomes. Comparing groups of people like the intersectionality on health equities, a nurse that has experience, peer, and manager support in place, like working as a team, as opposed to a nurse without these characteristics, will experience work differently. Just like how Ray and All article in 2020 argues that cultural norms affect the presence of health related stigma, the culture of the healthcare workplace influences the stigma around new nurses navigating the unit. And I want to talk a bit about stigma and power in healthcare. So Ray and All 2020 discusses about the different socioeconomic factors that influence how they are treated in society, how people are treated in society when needing healthcare. So Ray and All's article talks about some health issues that are not as um, prevalent in Canada. mainly leprosy, while there still is concerns about HIV, diabetes, and a bit of schizophrenia. So, um, the thing that I wanted to draw attention to relate to issues in Canada is that stigmatized beliefs arise when marginalized populations are involved. For example, if two people representing two economic classes both contacted HIV, a person from an upper class would less likely be judged as contacting HIV through shared needles, as opposed to someone homeless with HIV. Stigmatized beliefs surround the marginalized homeless population when they are in their houseless situation due to mental health issues, substance abuse leading to HIV, when the homeless client, in fact, could have contacted HIV before becoming homeless. In regards to the biopower article, which essentially talks about having the power to choose who will receive treatment and live and who will die, which does sounds pretty morbid. Um, I wanted to argue that biopower, in the article, it talks about more historical issues of biopower, such as with the Holocaust. Biopower still is present in marginalized populations, such as the homeless or those struggling with addiction. We see this with the case with Brian St. Clair, who died waiting in the emergency department and was neglected. He was judged to be under the influence of something, and instead of being assessed, he ended up dying of a UTI. And then something that was brought up in class was there was a sign on an ER department stating that they will be refusing certain care, that they will only take emergencies only. So there is another example of biopower present today. And talking about cultural safety and competency, the article from Curtis and all talks a lot about having that power residing within. Um, so, yes, we can learn about cultural competency and safety in ILEARNs and in post secondary nursing program. So, these are my takeaways. But the nurse must internalize that concept of power imbalance between themselves and the minority, for example, Indigenous communities. But it doesn't stop there. So, um, some of the key learnings that we have that have been bestowed upon us is that we need to sometimes be a whistleblower and to call out when acts of power abuse and cultural insensitivity occur amongst coworkers. Okay, and lastly, I wanted to talk, wrap it up about BCNU's um, announcement of the patient ratios. So while the posting says that this is going to be great, it's going to support patient safety and good bedside care, this is only really ideal for some. What about the clients going into emergency? So they they can't have patient ratios in an emergency department because what are the people going to do? Are they not going to be able to receive treatment at all? If the medical floor is booked up and they don't have the capacity to take on more clients due to the new ratio rules, where are the clients going to go? Will elective surgeries be postponed further? Will clients have to travel farther to receive joint replacement surgeries because their local hospital are is at their maximum ratios? So, with these considerations, I'm curious to know, will our employers be hiring more staff? Will there be faster discharges implemented? Will there be more delegation for home supports? And as a consequence, unfortunately, will things like home care be overburdened because the hospital's long term, well, not really long term care, it's not really applied to this situation, but um, will hospitals then just be delegating more clients to home care supports because they cannot take any more in the hospital? So just kind of going on this topic, um, some of my thoughts that came to mind is, what about more upstream approaches, such as teaching resilience and coping mechanisms, and having support resources in the community to help prevent chronic diseases like diabetes, coronary artery disease, respiratory diseases, mental health issues, etc. Excuse me. And I wanted to tie in the BCNU's um, posting about patient ratios to the YouTube video about the effectiveness of healthcare quality. So some of the things that that YouTube video talked about was intention of plan, and also timeliness. So intention of plan is, and then how it is to be done. So you'll start out with a goal in mind, and for example, with the BCNU patient ratios, the intention is that we're going to have smaller ratios, smaller caseloads for the nurses, and therefore patient care will be improved. But we will see how things unfold, as the emergency departments might have to turn away people, um, and uh, and that would be like worst case scenario. And the emergency departments are flooded with patients that cannot be admitted to the medical or surgical floors because they're at their maximum capacity of patient to nurse ratio. And then the timeliness of care, due to minimum patient ratios, can cause poor patient outcomes. Um, I want to talk lastly about forest plots in relation to the BCNU patient ratios. Um, and while the YouTube video talked about how he used the example of like a new medication versus an old medication and the effectiveness of each, um, the forest plots should be considered about, or can be considered about, the effectiveness of minimum patient nurse ratios between different countries. Might be a bit of a stretch, but just humor me. So, while this is beneficial to nurses, is it really helpful to the communities as a whole? Are there less barriers experienced in countries such as Australia, who have implemented this nurse patient health model? Um, uh, that have adopted the minimum patient ratio? Are there other influences to the success or demise of their healthcare system, such as wage rates? Do nurses in Australia get paid more as opposed to nurses in Canada? And is it just the fact that they have implemented this patient nurse ratio? So just because a certain healthcare model seems to work for other countries, there might be an additional reason why it's working, or perhaps it's not working that well. If you did digged a little bit deeper and did some investigation. So just because it seems to be implemented and possibly working well for one country, it doesn't necessarily mean that it will work for Canada. And that is all that I wanted to reflect on. Um, I'm going to just wrap it up. Thank you very much.